Good afternoon, everyone. Thank you for being here today. My name is Kanchana Perera, second year Western Sydney University PhD student, conducting my research under the primary supervision of Professor David Simmons. Today, I will go over the research that I am working on, which utilizes historical data and sample to evaluate ethnic disparities in type 2 diabetes in New Zealand. A bit of background into this research. So the global burden of type 2 diabetes has increased significantly in recent decades and will continue to soar into the next few decades. Currently, data indicate that type 2 diabetes affects approximately 422 million people worldwide and is projected to increase to 783 million by 2045, provided that no effective prevention methods are adopted soon. The most common complication of type 2 diabetes is nephropathy, and it is the leading cause of end-stage renal disease. I'm being mindful that not everyone here may be a medical professional, so let me start with a quick definition of type 2 diabetes. Type 2 diabetes is when your cells have become resistant to insulin or your body does not produce enough insulin to keep you healthy. Now, insulin is an essential hormone that helps your body turn food into energy and controls your blood sugar level. This research dives into the ethnic burden of type 2 diabetes and diabetic nephropathy in New Zealand. As of the end of 2022, there are over 250,000 people in New Zealand who have been diagnosed with diabetes, mostly type 2, where its prevalence is highest among Maori, Pacific people, and Asians. Maori and Pacific people are experiencing an epidemic of diabetes with its related complications of eye, heart, and kidney disease, as well as lower limb amputations, infections, and damage to unborn children. Maori and Pacific people with diabetes aged 40 to 79 years die at a rate of approximately 5% per annum, which is 4.5-fold faster than the rest of the New Zealand population and 2.7-fold faster than Europeans with diabetes. Diabetes is seen as one of the major problems facing Maori among our rural elders. Diabetic nephropathy is the leading cause of end-stage renal disease in New Zealand. Preventing or delaying the development of type 2 diabetes in those at high risk is essential to reduce the future incidence of diabetic nephropathy. In New Zealand, the Australia and New Zealand Dialysis and Transplant Registry shows the incidence of renal replacement therapy in Maori and Pacific people to be approximately 3 times the rate of New Zealand Europeans. This PhD project aims to use existing data and samples to evaluate ethnic disparities in type 2 diabetes and its associated complications, particularly diabetic kidney disease in New Zealand. Since there remains a rather large gap in our knowledge regarding the mechanisms behind the development of diabetes and its complications among Maori and Pacifica, we remain unclear as to the best way to prevent diabetes and the harm that it causes among Maori and Pacific people. We still need to find better ways to treat and prevent diabetes, including the best ways to ensure that those with diabetes access health services, have self-care, and are cared for in ways which is at the very limit of our knowledge. To progress, we must learn more and know more, and for this, we must undertake this research. The collective findings across the 4 studies in my PhD are implicitly important to bridge the research gap by identifying the biological risks, the metabolic characteristics, and the cultural or environmental determinants of diabetic nephropathy. The goal of the first study is to conduct a systematic literature review to identify, appraise, synthesize, and analyze the evidence presented in the published literature to provide a comprehensive overview of ethnic differences in diabetic kidney disease. The research approach for study 2 stems from the increasing evidence in New Zealand that type 2 diabetes in young adults is becoming more frequently observed, particularly amongst those aged 30 to 39 years, where this prevalence nearly doubles. The risks associated with type 2 diabetes amongst young adults of Maori or Pacific people show prevalences that are approximately 2 to 3 times higher than New Zealand Europeans. Within 15 years of youth onset type 2 diabetes, almost 2/3 had at least one diabetes-related complication, and nearly 1/3 had 2 or more complications. Most often, by the time these young adults are seen, their renal biomarkers are often already increased, which is a key indicator of kidney injury. The hypothesis for study 2 asked what are the socio-demographic and clinical risk factors which contribute to an increased risk of diabetic kidney disease in young New Zealand Europeans, Maori, and Pacific people with type 2 diabetes. The objective is to identify the ethnic differences in the associations between socio-demographic and clinical risk factors in those at increased risk of diabetic kidney disease. Next, I will present some preliminary results from study 2, where this pie chart shows that the ethnic breakdown of the 2,184 young adults in our data, comprising of 46% being Pacific people, 31% Maori, and 23% New Zealand Europeans. Statistical analysis showed that in comparison to New Zealand Europeans, Maori or Pacific people were significantly more likely to be female, more obese, more socioeconomically deprived, a current or an ex-smoker, where Maori have a much more pronounced increase, have been prescribed antihypertensive or anti-lipid medications, have UACR values over 3 milligrams per mole, and are at moderate or high risk of diabetic kidney disease. Additional statistical analysis showed that in comparison to New Zealand Europeans, Maori was significantly more likely to be younger and receive a type 2 diagnosis at a younger age. Compared with New Zealand Europeans, Maori or Pacific people were significantly more likely to have a higher BMI. And compared with New Zealand Europeans, Pacific people were significantly more likely to have a lower systolic blood pressure. Compared with New Zealand Europeans and Pacific people, Maori had significantly higher triglyceride HDL ratios, and higher eGFR values. Compared with New Zealand Europeans, Maori or Pacific people were significantly more likely to have higher HbA1c and UACR. This table provides the summary statistics resulting from another analysis called the logistic regression, which basically shows the association between the risk factor and diabetic kidney disease risk. The red arrows indicate that the risk of diabetic kidney disease increases with the increasing value of the input parameter. Just to break that down a little bit further, this shows that the odds of being at elevated risk of diabetic kidney disease for those prescribed antihypertensive is 75% higher than those not prescribed antihypertensive. The odds of being at elevated risk of diabetic kidney disease for Pacific people is 77% higher than the odds for New Zealand Europeans. There is a 32% increase in the odds of being at elevated risk of diabetic kidney disease for each unit increase in the log odds of triglyceride HDL ratio as a measure of insulin resistance. There is a 4% increase in the odds of being at elevated risk of diabetic kidney disease for each unit increase in age. There is a 1% increase in the odds of being at elevated risk of diabetic kidney disease for each unit increase in systolic blood pressure and also for each unit increase in HbA1c. That green arrow indicates that the risk of diabetic kidney disease decreases with the increasing value of the input parameter. So in this case, the odds of being at elevated risk of diabetic kidney disease for Maori is 30% lower than the odds for Pacific people. Based on these traditional stats analysis for study 2, we conclude that in comparison to New Zealand Europeans, Maori and Pacific people are more likely to have risk factors for diabetes complications, prescribed medications for high blood pressure and lipids. The significant predictors of diabetic kidney disease risk were prescribed hypertensives, ethnicity, triglyceride HDL ratio, index age, and systolic blood pressure. BMI was not a significant predictor of diabetic kidney disease risk. The research implications of study 2 are that BMI is unlikely to explain ethnic differences in diabetic kidney disease. Further strategies are needed amongst Maori and Pacific people to better identify mechanisms leading to renal disease in young adults. Further treatment strategies are needed to reduce the progression of diabetic kidney disease to end-stage renal disease. For example, earlier introduction of more intensive systolic blood pressure lowering. The research proposed for study 3 stems from prolonged diabetes having been related with microvascular complications, especially diabetic nephropathy. Diabetic nephropathy is the most common complication of type 2 diabetes, and it is the leading cause of end-stage renal disease worldwide. It is crucial to diagnose patients who are more susceptible to develop diabetic nephropathy for better control of the process of disease. There are several significant kidney damage and disease biomarkers which help in the early detection of diabetic nephropathy. Just a quick recap that biomarkers are defined as characteristic factors that can be objectively measured and assessed as an indicator of normal physiologic or pathogenic processes. So some examples of these biomarkers are proteins, lipids, microRNAs, genomic, metabolic, or proteomic patterns, electrical signals, imaging determinants, and cells present on a urine analysis. In study 3, the primary goal is to compare untested and/or new biomarkers for inflammation, endothelial dysfunction, podocyte function, and renal function between people with a first-degree relative with or without end-stage renal disease and or a first-degree relative with type 2 diabetes. The secondary objective of the study is to identify a microRNA signature for Maori and Pacific people with a first-degree relative with end-stage renal disease, with and without a first-degree relative with type 2 diabetes. As closing remarks for my presentation today, I'd like to address that Maori and Pacific people are more likely to develop nephropathy with type 2 diabetes. There are many epidemiological associations, but none that can fully explain this high risk. The young are particularly at risk since they have had type 2 diabetes for longer, which leads to increased comorbidity. Hence, it is important to intervene early. Biomarkers like microRNA may help identify metabolic pathways, which in turn can help in explaining the differences and contribute to the development of new interventions. That brings me to the end of my presentation today. I would like to say a special thank you to the Diabetes Foundation Aotearoa Board of Trustees for providing the funding for this research, and also extending my special thanks to my supervisors for their support and guidance along the way. Thank you for your attention. I hope you enjoy the rest of the summit, and please do direct any questions or comments to Professor David Simmons and or Dr. John Baker. Have a great evening, everyone. Bye-bye.